We're gonna now move from our previous sessions to a live molecular tumor board session. Like I said, you heard a little bit about it from me this morning from Dr. Kurzrock in her talk. And basically, this is the major component of TRACK. Every week we meet on Zoom. We discuss 1 to 5 patients, and this is a critically important meeting. There's a lot of MTBs in the world, of course, but we're in TRACK. I think it's unique, and we're really, really fortunate to have such an amazing group. So today in person, we have Dr. Rizal Kurzrock, Dr. Vivek Sabaya, Dr. Julia Elvin, Dr. Jason Siklik, and Catherine Skefos. And on Zoom, joining us remotely to preserve the spirit of what we do every week, we have Pradeep D and Dr. Meena Nakanjam. And not able to join today is Track Kopiai Shumei Kato and Dr. Jacob Adashek, as well as Letty Marquez, who is our medical acquisition specialist. This week is a bit of a weekly, or this meeting is a bit of a weekly miracle, I like to say, because there's so much work that goes into preparing patients to be presented each week, and that's all done by the track team, many of whom are also here today. And I just want to mention them. So Daniela Olanalua, who has been holding up the timing signs. Thank you, Daniela. Samantha Sullivan, Kristen Palma, and Marissa Palmieri, who's joined us. And she's the one who does all of the medical record extractions and also prepares the reports that come out of these meetings each week. She does a ton of work for us every week, all while going to med school. Not with us today, although I do see Carrie Lynn on Zoom, which is great, but we don't have them live in the room, is Mary Oster and Carrie Lynn Tompkins, who are a major part of the team as well and do all of the work to consent patients. They do all of our regulatory work and really just keep the operation going every single day of the week. So we're going to recreate this experience for all of you. We'll be discussing one patient today who has very generously consented to allow us to talk about him in a de-identified manner today. So thank you to that patient. And I'll turn it over to Dr. Kurzrock to get started. And I should have mentioned when I introduced Dr. Nakanjam and Pradeep, they are on Zoom. You can see their faces there, and they will be weighing in as well. So thank you.
Okay, so I've personally really enjoyed this meeting so far. And we're going to, as Jim said, we're going to try and, everybody can hear me, right? We're going to try and recreate the molecular tumor board, which is completely Zoom. And other than people that I've worked with before, I really feel I know these people really well, but some of them I've met for the first time today, which is pretty amazing. So just for all of, so I'm going to call on people to talk about their specific areas. But what we're going to do is we're going to discuss a patient with an ultra rare tumor called an amyloblastoma. So this is a great example of a tumor for which there's nothing. There's no FDA-approved therapies. Good luck finding a clinical trial. I am a seasoned oncologist. It's only the second patient I've seen in my lifetime. So this patient did go on track, but I actually see the patient in my clinic. So we're going to just recreate what we do on Zoom to the best of our ability. So this patient is a 73-year-old man. He has some comorbidities. He has some kidney disease, some diabetes, high blood pressure. He has what's called MGUS, which is a precursor to myeloma, and he had a very early stage melanoma that was surgically removed in 2017. He was adopted as a child, so there's no family history on file. And in September 2020, he was diagnosed with a maxillary amyloblastoma. And I'm going to get to this, but the place where amyloblastoma is derived from is important because amyloblastoma has specific mutations, and they're different depending on the area that it's derived from. He was treated with surgical resection. A couple of months later, But a year later, the tumor recurred, and it was felt to be that no more surgery could be done that could eliminate the tumor, and that radiotherapy could not be done because he would lose his right eye. So we did PET scans and MRIs to look at the tumor. And in January 2022, was enrolled on the TRACK study. And I want to emphasize again how nice that is. The patient lives actually in Wisconsin, and so he gets to stay home. It would have been very difficult for him. He wouldn't have had the means to travel as well. And that's another point, that people have to have a certain level of wealth in order to travel around the country. And we discussed the case in the molecular tumor board. This is the tumor, and the tumor is in the maxillary, it's in the head and neck area, and it's difficult to resect, and also it's as the tumor grows, it's pretty unpleasant for the patient. So I'm going to start by calling on Dr. Siklick and Jason Siklick, who's a surgical oncologist, although he usually does abdomens. So do you want to comment about resecting this tumor, or any comment there?
Yeah.
And
Thank
I
you.
don't know if you could speak up. I hope everybody can help you.
Yeah. Good morning, everybody. In terms of resection, as you said, the caveat being I'm an abdominal surgeon. I'm not a head and neck surgeon. But there's really three factors that go into making a decision about resecting a tumor. There's patient factors in terms of just whether they're physically fit to have an operation. There's factors regarding the technical aspects, whether you can actually safely resect that without causing significant injury or damage to things. And then there's the biology. In a situation like this, it really comes down to trying to get disease control with the biology, where we can then, or shrinking tumors down so that we can then safely thinking about resecting them. And so it's really trying to put all these pieces of the puzzle together. And this is where the drugs, we would think about trying to give somebody systemic therapy in order to have disease control, because the last thing we want to do is put somebody through some huge operation that's morbid or debilitating, and then only to find out that they've got disease recurrence at your first set of post-operative scans.
Okay, thank you. And then Dr. Julia Elvin, who is a molecular pathologist with Foundation Medicine. Do you want to comment on ameloblastoma?
Yes, so ameloblastomas are in the category of odontogenic tumors, which is significant for molecular testing. So as Dr. Kurzrock already mentioned, this is a very, very rare tumor. Molecular testing can also be complicated by the fact that the resections can involve the bones of the jaw, which sometimes lead to outside pathology departments treating the samples with a decalcifying agent to make them soft enough to section, particularly to get surgical margins if it's a resection specimen, or even in a biopsy if there are bone fragments. So the problem with this is that a strong acid decalcification basically dissolves the DNA, rendering the tissue unusable for molecular testing. So this can be one of the challenges with bone tumors, bone metastases, or in particular a jaw tumor like this. However, we were lucky, and in this case,
so we were able to do everything on this patient.
yes.
Okay, thank you. So this is his molecular aberrations. And just to point out, he had a PD-L1 expression at 60%, which is usually considered a marker for immunotherapy. And then he had a lot of other alterations, and I'll let Dr. Elvin comment as well.
Thank you. So this is a typical multimodality workup for a patient with a tumor that is rare, with a combination of some immunohistochemical stains being performed, as you see in the blue box here, on individual tissue sections, as well as the tumor being sent for broad panel genomic profiling. So a couple of things to note here. When this sample was received for testing, it was a high purity sample. And this is important for both getting a complete genomic profile result, but also having confidence in the absence of alterations that were not detected. So this, the tumor purity for this sample was assessed at over 50% of the nuclei in the sample. The other thing to note here with regard to the multimodal testing is that for small biopsies, that can use up a lot of tissue in sequential single marker tests. However, we were really lucky that both the pathology lab processed this without using the decalcification, and that there was still plenty of tumor left over to do the molecular profiling. So now if we actually turn our attention to the alterations that we found, this is a complicated tumor. We've got some alterations that are recurrent or recurrently associated with ameloblastomas, including the smoothened mutation, which is in the purple circle, and the FGFR mutation that is in the red circle. We also see here the allele frequencies that are high, which are consistent with the high tumor content of the sample. Interestingly, we do know that RAS alterations can be part of these tumors, but if you look, we detected a KRAS alteration, but at a lower variant allele frequency. We also have a number of other mutations here, TET2, ASXL1, and what's interesting is, and what complicates the interpretation of tumor testing, is that within the tumor tissue sample, we actually have multiple genomes represented. We've got the patient's germline background genome from all of the normal cells. We've got the tumor genome from the ameloblastoma, and then we can have elements of the hematopoietic genome for coming from invading inflammatory cells. And TET2, ASXL1, and are two genes that are commonly associated with clonal hematopoiesis. So these are very common things that we end up having to address when we interpret these complex reports to figure out which ones are likely coming from which compartment in that patient's sample.
Thank you, Julia. And I want to make one big point about this. Notice, and this harks back to something that we talked about earlier, notice that the patient has multiple alterations. So we think that one drug's not going to cut it. And then the question is, and there's only so many drugs that you can give safely to a patient. Then the question is, what drugs do you give to the patient? And then that's partly based on science, partly on experience. It's a developing field, and partly based on what drugs can we actually get. So there's operational characteristics to it too. I do want to mention that the CHEK2 alteration was found to be germline. So that means it's hereditary. And so it's in every cell of his body. And we're going to come back to that later. Catherine Skifos is going to address that because it's pertinent to how the patient did with time. This is these tumors, and the main point I want to make is that the tumors, even though they're super rare, they have two hallmark molecular aberrations. If they are in the maxilla, like this patient, they have something called a smoothen alteration. And that alteration can be targeted by a drug called vismodegib that is FDA approved. If they are in the mandible, they have a BRAF mutation. And Dr. Sabaya talked a lot about the BRAF inhibitors. So there's several BRAF inhibitors that can be used. This patient had a maxillary ameloblastoma, and he did have a smoothen alteration. And because these are such a trademark for this tumor, we felt that that would be an important target because it's found characteristically in this tumor type. And so this just goes over some of that information. But the main thing I want to point out is that smoothen activates something called the hedgehog pathway, and there's two FDA-approved drugs. One is called vismodegib, and another is called sunitinib, that counteract what smoothen does to drive the tumor. Now, these drugs are FDA approved for a different type of cancer, for cancer called basal cell carcinoma, and that's the first operational issue because in the United States, we are allowed to prescribe off-label drugs, and in fact, in oncology, we do it very often. But somebody has to pay for it, and we have to have a methodology of getting that. And so we do have a technique that we do have with Letty's help, a way to get the medications for the track, but that's always going to be an issue until we figure out how to get the precision paradigm really going for patients on a regular basis. Now I'm going to ask Dr. Pradeep D to talk about, he's a scientist at Avera Cancer Institute. We've had a long-standing collaboration, and could you just talk a little bit about your slides?
Yeah, good morning, I'm Pradeep here. By training, I'm a signal transduction biologist, and I'm working the track trial. I'm trying to interrogate the genomic alteration. And here, if you see, like Dr. Razal mentioned, that smoothen alteration is the key finding, the driver mutation in the ameloblastoma. And this, what it does, smoothen alteration, if you see the right part of top right part, the alteration is a hotspot alteration that is in lysine to phenylalanine at 412 position. So if this thing happens, then smoothen is activated, then patch-mediated smoothen inactivation is off, and SMO, that smoothen is activated. It activates the downstream gli. So gli is now out from the FU. So gli can move to nucleus, and since it is a transcription factor, it activates various mRNA like cell cycle, like CCND1 cell cycle gene, like MYC, like BCL2, and interestingly, it also activates patch1. So this is the smoothing signaling, and we can control it by vismodegib. This is the approved drug, like just mentioned, and there are several other drugs are available. And nowadays, the GLI inhibitor is also available, but it's not yet approved. Can I go for the next slide, please? The next slide is a little busy, I'm sorry. So here you can see the KRAS alteration as well as FGFR2. Here, KRAS alteration is a little bit different. This is not a very hotspot like G12C or G12D or G13D. It is the I24N, but this is the activating mutation, not hotspot, but activating mutation means it all perpetually binds with GTP. So it never hydrolyzes to GDP. So it is activated mutation. And there is another mutation, very important, FGFR2. This is a transmembrane domain alteration. This is cysteine to arginine 382. And FGFR signaling, it also goes through the RAS pathway as well as PI3K pathway. Here, RAS pathway is already activated by KRAS mutation, and FGFR signaling also goes through RAS. So there is a connection between FGFR signaling and RAS. And this part we not yet discussed that part. That is, this patient has the PIK3C alteration. That means the PI3K pathway is upregulated. FGFR2 activates RAS, and FGFR2 also has the capacity to activate PI3K. because there are some adapter protein. You can see my FGFR signaling tree. So there is FRS2, then GRAP2. GRAP2 classically activates RAS, but GRAP2 has the capacity to bind with the GAB1, this is another adapter protein. And this adapter protein has the P85 binding domain, and so activates PI3K. And this pathway already has the PIK3CA mutation. Although we believe if there is a RAS pathway alteration and PIK3CA alteration, single PIK3CA alteration, better to use the RAS drug and not to choose the PI3K drug. But here is one paper recently published by Damodaran. I believe that Vivek knows. This is from the MD Anderson's paper. The first author is Damodaran. There is a NCI match trial, and they use the copanlisib for amyloblastoma. There is one amyloblastoma patient, but I don't know this is a maxillary or mandibular amyloblastoma patient. But there is a PIK3CA alteration, and copanlisib works well for that patient. Next slide, please. This is the CHEK2. I believe the Catherine will discuss much more about the CHEK2, although it is a germline alteration. It present in the chromosome 22q12.1. And this alteration is codon C1008G2A. This is in exon 8. If you see my diagram, you can see there is an exon 8 mutation. And if the CHEK2 is an important gene, it is a DNA repair pathway gene. And if the CHEK2 alteration is there in germline alteration, you can get the breast cancer, get the prostate cancer. And because the CHEK2 pathway, CHEK2 is activated by upstream ATM. So CHEK2 is phosphorylated at threonine-68. Then CHEK2 is getting dimerized and activates. Intermolecular phosphorylation is taking place. So CHEK2 is fully activated. This kinase is fully activated. So now CHEK2 can control the cell cycle by CDC, CDC25A, and they control the cell death by P53 and also control the DNA repair by BRCA or CAP1. So when this thing happens, DNA damage, then CHEK2, when it is fully activated, it phosphorylated CAP1 and promote the DNA damage repair. So there is a possibility you can use that PARP inhibitor. There are several PARP inhibitors approved. So like olaparib, like talazoparib, all the PARP inhibitor is approved. And also you can use the platinum drug. This also works in CHEK2 mutated situation.
So thank you. So I think the main point we want to get across here is that it's really important to have a really good scientist involved, because these are complicated genes, and understanding exactly what they do is really not simple. And if we don't have a scientist as part of our multidisciplinary team, it's Google, and that's maybe not the best thing. There is, despite how rare it is, there is a case report of tumor regression after treatment with a drug called lenvatinib, which is FDA approved, and it's an FGFR inhibitor in an FGFR2 mutated amyloblastoma. So we do consider what's in the literature as well. There might not be very much literature. There's very little about amyloblastoma, but this was a case report, and we thought that that was important. So the next, I'm going to turn it over to Dr. Sabaya, and if you want to come up here. And he will talk about our clinical trial options. So this is what we usually do. We go through the science. We go through the patient, we go through the science. Dr. Sabaya talks about the clinical trial options, and then we talked about the customized combinations.
Thank you so much, Dr. Kazrak and the team. And you can see here that we have several driver alterations. And, again, there is not a single drug approved for this particular indication. So, when we look into clinical trial options, we'll go through the list, and we'll also discuss the challenges of clinical trials. When I showed in my previous presentation on the waterfall plots, right, we see too much shrinkages, but we don't, our ultimate goal is to get complete responses in all patients. Mainly because, all those patients, we are impacting on one of the alterations, but most of the patients have co-occurring driver alterations that we are not able to address with the current clinical trial infrastructure, right? So let me go through the clinical trials available for this particular patient, and also discuss the challenges and what we need in the future in order to offer customized combinations for patients. Again, we saw a driver alteration in this patient. Of course, there was a nice case report with lenvatinib. Lenvatinib is a pan multikinase inhibitor. Of course, with the pan multikinase inhibitor, it comes with toxicity challenges of VEGF blockade and others, hypertension, hand-foot syndrome. So again, what are the FGFR2 focused options? One is the refocus study. The data was recently presented for cholangiocarcinoma patients, showing like over 80% responses in patients with FGFR2 mutant frontline cholangiocarcinoma. So this data, this trial is open. Another trial is a kinase inhibitor study, again open for FGFR2, FGFR3 alterations. Again, one of our colleagues here asked this question about how to develop these drugs. This shows how they are developing this drug. One is mainly they are focusing on this is a refocus study, a global seamless phase 1/2 open trial of this drug, FGFR2 specific drug. They are focusing on a pivotal cohort with cholangiocarcinoma, which is FGFR2 driven. And beyond that, they're going to also enroll a long tail of tumors, including FGFR2 driven amyloblastoma, among others. So this is an option for this patient if the patient will be eligible. But this only targets FGFR2 alteration. The next option, the patient also has a PI3K alteration. The option could be the LOXO oncology study with LOXO 783, which is a mutant selective PI3K inhibitor that drugs just the H1047 series. Another option is also another mutant selective PI3K inhibitor, in this case RLY2608 in advanced solid tumor patients. And another option, patient has a germline CHEK2 alteration. So another option is there is this drug called lurbinectedin that's been recently approved for small cell lung cancer, and it's shown to have activity in BRCA mutant breast cancers. And based on that data, the eMERGE 201 study is enrolling patients who have all these HRD alterations, germline or somatic. So that's an option for this patient. And another option is a talazoparib, which is a PARP inhibitor in patients with advanced cancer and DNA repair variations. So that would be another option as well for clinical trials. So one of the challenges, with oncology, as you can all see, is we have multiple driver targets, and if we can enroll a patient on the FGFR, the patient may have a response, briefly, and may progress, and then the patient may have be enrolled on a PI3K trial. Patient may have a brief response and progress, and then a CHEK2. So cancer, as we see, has multiple co-occurring driver alterations, and it's an ultimate whack-a-mole game. And in fact, Dr. Shumei Kato and Dr. Kurzrock led a clinical trial study that was published in Clinical Cancer Research, and we were fortunate to write an editorial piece on that paper. That cancer is an ultimate whack-a-mole game. So how do we address these? With a MEK inhibitor, with a CDK. In this case, how do we go after the FGFR2? How do we go after PI3K? What sequence? What order? I think these are questions that remain to be answered. And Dr. Kurzrock always says, cancer is a snowflake. So the current paradigm is, if this patient comes to my clinic, I would probably offer one clinical trial targeting one of these alterations. The future paradigm, which is the track paradigm, is customized combination therapy. So Dr. Kurzrock, I'll hand it over to you so that you can take the slide set from here. So the future paradigm is today with the track study.
Okay, well, thank you. So again, we're just trying to recapitulate what we actually do in the track. So we talk first about the clinical trials, and then we talk about other options. So this is what we talked about this patient. This patient has SMARCB1 alteration. this is a chromatin remodeling gene, and there's data that it sensitizes to immunotherapy in other tumors. It's not a lot of data, but it's good clinical data as well as preclinical data. And the patient also had a high PD-L1, which also is a biomarker for immunotherapy. So we thought about using an immunotherapy like Opdivo or Keytruda, which is nivolumab, or pembrolizumab. There are other ways to target this alteration, but that was one of the ways. And then we thought about how are we going to put all the drugs together. We're going to do more than one drug, and I'll get to what we actually did. But maybe Dr. Jason Siklik can just address briefly the studies that we did at UCSD, where we did match combinations with the iPredict trial, which you led.
So the iPredict trial, as you alluded to earlier in your talk this morning, was basically a trial focused on investigating customized combination therapies, based on this paradigm that just hitting one target, would be insufficient. And so on that trial, which ultimately enrolled 505 patients, and we've, as Dr. Kurzrock has here in the references, our papers that were published in Nature Medicine, and we have another one that was published in Genome Medicine, looking at patients that were previously treated as well as patients that were treatment naive. What we basically went on to show was that those patients that had higher molecular matching, meaning hitting more than one target, hitting multiple targets, did better. And even taking it a step further was actually that there was actually a linear correlation between how patients responded to therapy in terms of their survival outcomes, as well as their responses on the CT imaging or MRI imaging relative to how many targets we hit.
Okay, thank you. Jason was a phenomenal collaborator at UCSD. We have to have offices next to each other. So that's how we discovered each other, but he was really a phenomenal collaborator. So let me tell you what we actually did for the patient based on the recommendations of the Molecular Tumor Board. We decided that we should target the FGFR2 with lenvatinib because of the case report. We decided that we should target vismodegib because we think it's a driver alteration because it's found in almost all patients with maxillary amyloblastoma, and vismodegib targets smoothen. And then we really wanted to target the SMARCB1 and the PD-L1 with immunotherapy. We plan to use pembrolizumab. I favor immunotherapy if there's a biomarker because some patients treated with immunotherapy are cured. And so I don't give immunotherapy if there's no biomarker, but if there's biomarkers for immunotherapy, I tend to incorporate it into the regimen. So we started the lenvatinib, and I just want to mention that we lower the doses for safety. So the normal dose of lenvatinib is 24 milligrams daily. And it's actually a drug that we're very familiar with because we developed it when I was at MD Anderson. But we lowered the dose to 10. So that's about 40% of the dose. And we know that the lower doses work, and it decreases the incidence of toxicity. Vismodegib is given 150 milligrams every day. We lowered it to every other day. And then we gave the full dose of the immunotherapy, the pembrolizumab. Unfortunately, even though we were cautious, the patient had developed a side effect, and he developed some high blood pressure, some kidney issues, and he's sort of a frail person, some intermittent confusion. So we actually stopped the lenvatinib, and he was better within about 3 or 4 days. And we elected that we would just continue the vismodegib, which is the smoothen inhibitor, and the immunotherapy, the pembrolizumab, and he's done well on that. And then, I wanted to call on Dr. Nakanja, who is also on faculty at UCSD, and to speak about individualized dosing because she's written a lot about that.
Thanks, Dr. Kurzrock. I want to say with novel combinations, it's really critical to start at doses that are low enough that they're going to be safe and tolerable to the patient, but we also want it to be high enough to provide an efficacy. Because if you go at a very low dose, it's probably not going to do anything. So Dr. Kurzrock and I previously studied about 75,000 patients on phase 1 through 3 clinical trials who were receiving novel combinations to determine what reasonable, safe, and starting doses would be. And based on these studies, we put together a set of rules that help guide us in our precision medicine clinic and the TRAC tumor board about where to start these combinations. So based on these findings, we would generally start 2 small molecule inhibitors like lenvatinib and vismodegib at about a 50% dose. Antibodies like pembrolizumab are generally better tolerated, so most of these can be started at full dose, which is what you can see here with the dosing. And then you start here, see how the patient's doing, and then titrate up to maximize efficacy while at the same time maintaining tolerability.
And if we're doing novel combinations, which is not typically done in oncology, although we've done now hundreds of patients safely, we see the patient at the beginning weekly to see how they're doing with the drug. And we start at lower doses and we titrate them up to the highest tolerable dose for them. So this is the response. He's had a beautiful response. You can see on your left-hand side that the PET scan is very metabolically active and it's gone inactive. He's still on. He started treatment end of January, I think, and early February. And this was his most recent PET scan in July. So you can see that. And then he's had MRIs and you can see the shrinkage in the MRI from the baseline in January, continuous shrinkage through the last MRI was on August 31st, and he is symptomatically much better. He had a lot of symptoms from this mass in the head and neck area, and he's symptomatically much better. He also, we did blood testing to follow up on what was happening to the mutations. And I think what you can see is from the original testing in November to June, many of the mutations are no longer detected in his blood, which is consistent with the treatment response. And I will let Dr. Elvin comment on this as well.
Thank you. Yeah, so as Dr. Kurzrock mentioned and Jim mentioned in the introduction, one of the novel diagnostic features of the TRAC trial is having the option to do both tumor tissue testing and liquid biopsy on these patients at various points along their treatment journey. So in this patient, we have under the heading of 11.8.21 is the findings from actually the tissue-based testing that was performed on that biopsy sample that we talked about earlier, compared to the findings in his cell-free DNA taken from a peripheral blood sample. So as Dr. Kurzrock mentioned, so if we look down in the red circle where we focus in on some of the driver mutations that we've already spoken about and where therapy directed against those alterations was given, we can see that we are not detecting those in the circulating or the cell-free DNA. Now, you know, one of the cautions about liquid biopsy is unlike tumor testing, you cannot determine what the ratio of the cell-free DNA that is coming from the tumor cells versus the just background normal cells that are shedding into the circulation versus potentially other genomes such as the hematopoietic cells. So we have to interpret these results with some caution. One possibility is that this is actually a marker of response to these therapies. However, another is just that with overall lower activity of the tumor, we may have less shed coming from that particular compartment. The other thing that I think is really something that this particular test is illustrative of, and also a cautionary tale to all of us who are practicing this kind of precision diagnostics in medicine, is that we can see some of the alterations that we touched on earlier in the top part, where we detected them in the tissue and actually detected some of these alterations at low variant frequencies. And now when we look at them in the blood, their variant allele frequency has gone up. And one of the explanations for this is because this could represent tumor heterogeneity that wasn't captured in the tissue testing. But the other thing that the blood sample does is it pulls in alterations from other compartments, such as the hematopoietic system. And remember, this patient had come in with a diagnosis of MGUS, that's a plasma cell dyscrasia. And so, while we know that RAS alterations, KRAS and NRAS, can be found in ameloblastoma and could potentially be reflecting evolution and resistance of the tumor to the targeted therapy under the pressure that those agents provide, we also have to take into account and know that plasma cell neoplasms can also be driven by RAS alterations. And the fact that we see these now and they're high in the blood brings that into our consideration and part of what we discuss. Because certainly if we're trying to give targeted therapy for the ameloblastoma, but we're targeting alterations coming from some other compartment, that may be counterproductive for the particular clinical situation.
Okay, thank you. So these were some of the other potential treatments discussed in the molecular tumor board, PARP inhibitors, which Dr. D mentioned for the CHEK2 alteration, PI3 kinase inhibitors because of the PIK3CA mutation, EZH2 inhibitors because of SMARCB1, which can also be targeted by EZH2 inhibitors, and MEK inhibitors like trametinib that target the MEK pathway, KRAS and NRAS. But as I said, we chose the other inhibitors because we chose the lenvatinib, the vismodegib, and the pembrolizumab because we thought that they were the most important. And then I just want to finish, and I'm going to call on Catherine Skifos to address this. I mentioned that he had a hereditary germline CHEK2, and he's done extremely well with the ameloblastoma. He has a nice partial remission. He feels well, but he has some new problems popping up. He's developed a 2-centimeter melanoma on his back. He's developed a separate small melanoma on his scalp. He has developed from pre-myeloma, he now has frank myeloma. So Catherine, can you address CHEK2, and is this usual or unusual?
Absolutely. So to go back to our initial somatic testing for this patient, that CHEK2 alteration stood out as potentially of germline origin due to the variant allele fraction, and also the fact that CHEK2 doesn't quite go along with ameloblastoma. It sort of stood out as an outlier. We would recommend dedicated germline testing to confirm that it is of germline origin. And although it may not directly benefit the patient, other than potential treatment options that were discussed, it could certainly have an impact on his family members, given that we know that individuals with a germline CHEK2 mutation have an increased risk of breast cancer for females. Instead of about a 12% background risk, a woman with a CHEK2 mutation has up to a 40% chance of developing breast cancer in her lifetime. We therefore would recommend for any affected females in the family to start breast screening in her 30s instead of waiting until a bit later, and to supplement annual mammograms with annual breast MRIs. Likewise, there's a slightly increased risk of colon cancer, enough to warrant beginning colonoscopies slightly earlier than in the general population. For this patient in particular, none of the cancers that he has had seem to be related to this CHEK2 alteration, which is sort of supported by the fact that we didn't see a second hit in the CHEK2 gene on the somatic testing, which might indicate that it was more of a driver of the tumor. When it comes to melanoma risk, CHEK2 has been implicated as a preliminary evidence gene that may influence melanoma risk, but we know that there are many other risk factors for melanoma that could have played a larger part for this patient. And the last thing that I wanted to note was that for any patient with a potential hematologic malignancy, the gold standard for germline confirmation really is a skin punch biopsy if done on healthy tissue. That is recommended to avoid potential contamination, if you will, from any potential drivers of the hematologic malignancy. Although in some cases, when you know what you're looking for, in this case, we knew that it was a CHEK2 alteration that we were looking for, we can pretty much trust the blood testing as well, but it just avoids, when you do a skin punch biopsy, it avoids that potential cropping up of mutations of somatic origin rather than germline origin.
Thank you. So that gives you a feel for the MTB. I know we were running late before and we didn't catch anybody up. Jim, no questions or questions? Should we open it up for questions or you want to?
We're pretty late.
What?
We're pretty late.
Okay, so we want you to have lunch. So you know where we are. You can approach any of us and we will be happy to answer questions for you. But I hope you got the flavor of the molecular tumor board. Thank you.